Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical. And for today's deep dive, I want you to imagine a scenario. If a 40-year-old and a 10-year-old suffer the exact same catastrophic internal bleeding from a high-speed car crash, pumping the exact same ratio of medical fluids into both of them will likely save the adult.
Right.
And it will kill the child.
Exactly. It's a terrifying reality.
Yeah, so for decades, emergency medicine operated under this fundamentally dangerous assumption. This idea that children were simply, miniature adults. You took the adult trauma protocol, you divided the fluid dosages by half because the patient was half the size, and you just kind of crossed your fingers.
Expecting the exact same physiological response, yeah, which is incredibly flawed.
Right. Because when we look at the data, the reality is stark. Trauma remains the undisputed leading cause of death in children and adolescents. It's not genetics. It's not infectious disease. It is kinetic energy destroying tissue. And today, we are unpacking two massive data sets that prove exactly why that miniature adult assumption is so deadly.
And honestly, it shows how the leading edge of pediatric trauma surgery is finally rewriting the rules. That miniature adult fallacy is really the biological mystery at the heart of our discussion today.
Yeah.
Because when you step into the world of pediatric trauma resuscitation, you are dealing with an entirely different physiological landscape. I mean, a child's cardiovascular system compensates for blood loss differently.
Their tissues repair themselves differently.
Exactly. Their coagulation cascade, the very way their blood clots operates on a completely different threshold than in adults. Treating them requires a hyper-specific understanding of pediatric pathophysiology. You can't just use a scaled-down adult flow chart.
Which brings us to our mission for this deep dive. We are looking at two game-changing studies from the year 2024, both published in the Journal of Trauma and Acute Care Surgery. And our goal for you, the listener, is to really understand the cutting-edge science of keeping profoundly injured children alive.
It's vital stuff.
It really is. So the first study, led by Feeney and colleagues, attacks the fluid problem. It looks at the exact ratio of whole blood to total blood products used when resuscitating injured children. And the second, a multi-center study by Nadich and colleagues, looks at mechanical source control.
Right. They analyzed the incredibly rare use and the highly controversial timing of a procedure called angioembolization in pediatric blunt liver and spleen injuries.
And the through line here is precision. Both of these studies are pushing back against generalized legacy protocols and demanding that we look at the specific, unique biological responses of a bleeding child. Okay, let's unpack this biological mystery, starting with the fluid dynamics.
Let's do it.
The Feeney study focuses on the administration of LTOWB, that's low-titer group O whole blood. And to understand why this paper is making such waves in the pediatric trauma community, we really have to look at the history of trauma resuscitation, right?
Oh, absolutely. The historical context is everything here.
Yeah, because over the last few years, a mountain of observational data has shown that giving this specific type of whole blood improves survival and decreases the total amount of blood products needed in adult trauma patients. So naturally, pediatric trauma centers are looking at that adult success and asking, well, how does that translate to our pediatric base?
Right, but to grasp the magnitude of this shift back to whole blood, we really have to understand the flawed logistics of what we've been doing for the last 40 years. Because the gold standard in trauma base has long been component therapy.
Right, component therapy, which is essentially taking donated blood, spinning it down in a centrifuge, and splitting it into its distinct parts.
Wow.
You've got packed red blood cells, plasma, and platelets. But the logic there was never really driven by what was biologically best for a bleeding patient, right? I mean, if I'm thinking about an analogy here, it's kind of like trying to bake a cake by eating the raw ingredients separately. You eat a cup of flour, you eat a raw egg, you eat a spoonful of sugar, and you expect your stomach to magically bake the cake.
That is a perfect way to look at it because component therapy was entirely an inventory management solution. It was a logistical compromise for the blood banks.
Wait, really? Just for inventory?
Yeah. Red blood cells, plasma, and platelets all have vastly different optimal storage environments. Platelets are the most fragile, they have to be kept at room temperature, constantly agitated on a shaking tray, and they expire in about 5 days.
Oh, well, 5 days is nothing.
Right. Meanwhile, red blood cells need to be refrigerated to last a few weeks, and plasma is frozen and has to be actively thawed before you can even use it. So by separating whole blood into these components, blood banks maximize the shelf life of every single donation.
That makes sense from a supply chain perspective, sure.
But here is the physiological disconnect. When a trauma patient is bleeding out on the table, they aren't losing isolated red blood cells, they are losing whole blood.
Right, they are losing the entire balanced ecosystem of their circulatory system. So when we try to reconstruct that blood in a chaotic trauma, hanging a bag of cold, concentrated red blood cells, waiting around for the plasma to thaw, pushing room temperature platelets, we are creating a Frankenstein fluid.
A Frankenstein fluid is exactly what it is, and the chemical reality of that process is what triggers the lethal triad of trauma.
Ah, the lethal triad. Hypothermia, acidosis, and coagulopathy.
Yes. This is where the biological cascade really turns against the patient. When you pump refrigerated red blood cells into a bleeding child, you drop their core temperature. That hypothermia directly impairs the enzymatic reactions that are absolutely necessary for blood to clot.
And then you have the acidosis on top of that.
Exactly. Stored blood components are preserved with citrate, which is an anticoagulant. And the problem with citrate is that it binds to calcium.
And for anyone who knows the clotting cascade, calcium is the crucial factor for VA.
Precisely. So by pumping in heavily citrated separated components, you are actively stripping the child's blood of the calcium. It desperately needs to form a clot.
You're basically sabotaging the body's own defense mechanism. You're diluting the clotting factors and worsening the acidosis.
That is trauma-induced coagulopathy in a nutshell. The adult trauma world realized that reconstructing blood from separate cold citrated bags was failing, so they moved back to LTOWB. Group O makes it the universal donor type.
And low-titer means it has mathematically low levels of the anti-A and anti-AB antibodies, right?
Yes, making it safe to administer rapidly before you have time to cross-match the patient's specific blood type. You are giving the patient exactly what they are losing: warm, balanced, functional blood.
So the adult world has largely embraced this.
Right.
But as we established right at the top, kids aren't little adults. And the Feeney study points out a very sharp, specific gap in the pediatric literature. They weren't just asking the binary question of, does whole blood work in kids?
Right, because most prior retrospective work just looked at whole blood in addition to balanced component therapy. They didn't really look at the dosage.
Yeah, the Feeney team asked a much more sophisticated question about the dose dependency. They focused on the WB to TTV ratio, the whole blood to total transfusion volume ratio. Basically, of all the life-saving fluid pumped into this dying child's veins, what percentage of it was the pure, unseparated whole blood?
That nuance is the core of their entire investigation. Because in a pediatric trauma bay, resuscitation is a dynamic, fluid process. You might start with the 2 units of whole blood you have in the rapid infuser, but if the child is still bleeding, you run out.
And you have to pivot immediately to component therapy.
Exactly. So the researchers wanted to know, is there a critical proportion of whole blood that dictates survival?
Let's look at the cohort they analyzed, because the demographics here paint a really stark picture of the acuity we are discussing. This was a single-center retrospective cohort study of 95 injured children who received LTOWB in the first 4 hours after their injury. The median age was 10 years old, 58% were male, and 25% suffered penetrating injuries.
And we should note, in pediatric populations, a 25% penetrating injury rate is notably high.
Yeah, that usually points to a high volume of firearm injuries.
Sadly, yes, which bring massive kinetic energy and devastating cavitation to the internal organs.
Exactly. And that devastation is reflected in their severity scores. The median injury severity score, the ISS for this group, was 26. Now, for you listening, you likely know that an ISS over 15 generally categorizes a patient as having sustained major trauma.
But the nuance of a 26 and a 10-year-old is entirely different from a 26 and a 40-year-old.
How so? Walk us through that.
It's a completely different physiological state. Children possess an immense physiological reserve. Their sympathetic nervous systems are incredibly robust. If an adult loses 20% of their blood volume, their blood pressure drops, they get tachycardic, they show obvious signs of shock pretty quickly.
For a kid.
If a child loses that same proportion, their peripheral vasculature clamps down so aggressively that they can maintain a perfectly normal systolic blood pressure even while they are actively bleeding to death internally.
Wow. So they look totally fine on the monitor until they just aren't.
Exactly. They look stable until their reserve is suddenly exhausted and then they fall off a cliff physiologically. They code almost without warning. So an ISS of 26 means this child has multiple catastrophic systemic injuries.
Like a shattered pelvis and a grade V liver laceration, maybe.
Right, and their body is walking an invisible tightrope.
And to complicate that tightrope walk even further, 45% of these 95 kids had severe traumatic brain injury or TBI on top of their bleeding. The overall in-hospital mortality for this entire group was 34%.
Roughly 1 in 3 of these children did not survive the hospital stay. These are the absolute sickest of the sick.
Which highlights why optimizing every single variable in their resuscitation is literally the difference between life and death. So let's look at the fluid volumes they actually received. The median volume of whole blood transfused into these kids was 17 milliliters per kilogram of their body weight. And mathematically, that whole blood made up a median of 59% of their total blood product resuscitation.
Right.
But I have to push back on the clinical reality here. If whole blood is the superior, perfectly balanced biological fluid, why was the median only 59%? Why wouldn't a trauma surgeon just demand 100% whole blood for every bleeding child?
It's a great question, but it's because the trauma bay does not exist in a theoretical vacuum. It is constrained by intense logistical realities. LTOWB is an incredibly precious, finite resource.
It's just hard to get.
Very. It is not universally available at all pediatric trauma centers yet, though the movement to stock it is gaining momentum. Blood banks have to meticulously source it from male donors who naturally possess those low antibody titers. They have to test every single batch. As a result, a pediatric center might only have a strict allocation of a few units in their trauma cooler at any given moment.
Oh, I see. So if a child comes in with a massive splenic avulsion
And bleeds through those initial units of whole blood in the first 15 minutes, the surgical team has no choice. They have to immediately pivot to whatever else is available to maintain perfusion to the brain and heart. That means falling back on the component therapy, the packed red blood cells and thawed plasma. They use the golden fluid until it's gone, and then they use whatever keeps the tank full.
Got it. Okay, here's where it gets really interesting. The researchers took all this messy, real-world data. You know, the kids who got 10% whole blood, the kids who got 50%, the kids who maxed out at 90%, and they mapped it against survival. And the primary outcome is just staggering. There was a massive 38% decrease in in-hospital mortality for each 10% increase in the proportion of whole blood relative to the total transfusion volume.
Yeah, that is the biological signal cutting right through the noise. For every 10% more of the total fluid that was pure whole blood, the child's chances of dying dropped by nearly 40%.
That's massive. And the statistical significance here is incredibly tight, isn't it?
Extremely. The p-value was less than 0.001. In clinical research, that means there's less than a 1 in 1,000 chance that this correlation is just a random fluke of the data set.
So if I'm a trauma surgeon, I'm thinking, I need to drive that percentage as high as mathematically possible. But the researchers actually wanted to provide a tangible, actionable target for these hospitals, right? They wanted to find the magic number. How do they figure out the exact threshold where the survival benefits really kick into high gear?
They utilized a statistical metric known as the Uden index.
Okay, unpack that for us.
Yes. Well, in any diagnostic or therapeutic continuous variable, finding a cutoff point is a delicate balancing act. If you set the threshold too low, you dilute the clinical benefit. But if you set it too high, say demanding 90% whole blood, it becomes an unrealistic logistical target that no blood bank can actually support.
Right, because of those inventory limits we just talked about.
Exactly. So the Uden index analyzes the receiver operating characteristic, or ROC curve, of the data to mathematically identify the exact point that maximizes both sensitivity and specificity. It isolates the optimal physiological sweet spot.
And what was that sweet spot for pediatric survival?
The math revealed that a WB to TTV ratio, whole blood to total transfusion volume, greater than 40% was the critical inflection point.
Greater than 40%.
Yes. If the trauma team could ensure that more than 40% of the total blood products administered were whole blood, it was significantly associated with lower adjusted odds of in-hospital mortality.
But hold on. This is where we have to put on our critical appraisal hats because retrospective data is inherently messy. You are looking backward in time at 95 completely different clinical trajectories. Some kids had gunshot wounds, some were crushed in rollovers, some were 15-year-olds with mature physiologies, some were 4-year-olds.
It's a huge mix.
Right. So how do the researchers confidently claim that the ratio of whole blood was the specific variable that saved them, and not just the fact that the kids who survived happened to have less catastrophic injuries to begin with?
That is exactly the pushback required when reading retrospective cohort studies. The authors knew they had to control for that inherent bias. To isolate the effect of the whole blood, they didn't rely on raw, unadjusted survival rates. They constructed a multivariable logistic regression model.
Which means?
Conceptually, they built a mathematical framework that adjusted for the heavily confounding variables. They controlled for the patient's age, their sex, the specific mechanism of injury, that incredibly high injury severity score, their Glasgow Coma Scale score, and their shock index.
And let's touch on the shock index in kids, because you mentioned their physiological reserve earlier. The shock index is simply the heart rate divided by the systolic blood pressure.
Right.
In adults, a normal index is around 0.5 to 0.7. If an adult's heart is racing at 120 and their blood pressure is tanking to 80, their index shoots up to 1.5, signaling profound hemorrhagic shock. But in kids, because they maintain that systolic blood pressure through aggressive vasoconstriction for so long, a rising shock index is an even more terrifying lagging indicator.
Precisely. By the time a child's shock index is highly elevated, they have already exhausted their compensatory mechanisms and are in the late stages of cardiovascular collapse.
So by mathematically adjusting for all these massive factors, how fundamentally broken their bodies were, how deep into systemic shock they were, how compromised their neurological status was, the multivariable model still demonstrated that hitting that 40% whole blood ratio was an independent, statistically significant lifesaver.
It held up under all that statistical pressure, yes.
Speaking of compromised neurological status, we need to address the TBI subgroup, because 45% of these kids had severe traumatic brain injuries. Bleeding in the brain fundamentally changes the rules of resuscitation. Did the whole blood ratio hold up for them?
It did, but the authors are appropriately cautious here. They found similar positive mortality trends in the severe TBI subgroup, but they explicitly note the limitations. The sample size of that specific cohort was small. Furthermore, kids with severe TBIs overall receive less balanced resuscitation volumes.
Because of the Monroe-Kelly doctrine, right? The
Yeah.
physiological nightmare of managing two competing catastrophic injuries at once.
Exactly. The Monroe-Kelly doctrine dictates that the skull is a rigid, closed box containing blood, brain tissue, and cerebrospinal fluid. If you have a traumatic hemorrhage or swelling inside the brain, the pressure inside that box skyrockets.
Because the skull can't expand.
Right. So in trauma management, dealing with a TBI often involves a strategy of fluid restriction to prevent exacerbating that cerebral edema. You want to keep them relatively dry.
But if that exact same patient also has a shattered spleen and is bleeding into their abdomen, you absolutely need to give them aggressive fluid resuscitation to maintain systemic blood pressure, or their organs will undergo ischemic death.
It is the ultimate clinical catch-22. The trauma team is walking a tightrope between swelling the brain and starving the organs. So while the TBI data for whole blood is very promising, it requires dedicated prospective study to fully understand the volume dynamics.
Which perfectly transitions us into the limitations of the Feeney study as a whole. As rigorous as the regression models were, it's not a flawless paper.
No paper is.
True, it is retrospective, meaning they are mining old charts rather than controlling the variables from day one in a prospective randomized trial. The sample size of 95 kids, while representing a high volume of pediatric tragedy for one hospital, is relatively small for definitive statistical modeling.
And it is a single-center study out of Pittsburgh, meaning we are looking at the success of one highly specialized academic protocol that might not translate perfectly to a community trauma center in a different region.
Right. And what about the timing?
That is the most critical encumbrance, which the authors transparently acknowledge, by the way. It's the unclear timing of the administration. Retrospective chart reviews rarely capture the exact minute-by-minute sequence of a chaotic resuscitation.
Because it's moving so fast.
Exactly. Did the children receive all their whole blood in the first golden 15 minutes and then transition to components for the next 3 hours? Or were the whole blood and components administered simultaneously through different IV lines? The precise temporal delivery of that 40% ratio remains an unknown variable.
Despite those caveats, the ultimate conclusion of the paper is a powerful directive. The authors state that LTOWB should be used as a first-line resuscitative fluid in injured children when available. The biological rationale, backed by a 38% drop in mortality, is simply too loud for the pediatric trauma community to ignore.
It really is a profound paradigm shift in how we view pediatric coagulopathy. But, as any trauma surgeon will tell you, there is a hard biological ceiling to fluid resuscitation.
Right. You can perfectly optimize that whole blood ratio. You can prevent the lethal triad and keep their coagulation cascade intact. But if a grade V splenic laceration is actively dumping all that pristine blood into the abdominal cavity, the physiology collapses anyway.
Fluid doesn't fix a hole.
Fluid doesn't fix a hole. The mechanical leak has to be stopped. And that connects us directly to our second paper today, the multi-center study by Nadich et al., which shifts our focus from fluid resuscitation to actual physical source control in blunt liver and spleen injuries.
So let's set the clinical stage for these specific injuries. For a stable pediatric patient who sustains a blunt force injury to their liver or spleen, perhaps from a severe tackle in football or the handlebars of a dirt bike jamming into their abdomen, the gold standard of care for decades has been non-operative management, or NO.
Which is the clinical term for watch, wait, and let the body heal itself. Instead of rushing them to the operating room and opening their abdomen, you admit them to the ICU. You monitor their hemoglobin levels meticulously, you enforce strict bed rest, and you rely on the child's innate biology to form a clot and heal the organ.
And historically, the pediatric success rate with NU is astronomically higher than in adults. It is one of the most fascinating aspects of pediatric physiology.
Kids really do bounce back.
They are incredibly resilient in this specific regard. Their splenic architecture is fundamentally different, They have a thicker, more robust splenic capsule containing a higher density of myoepithelial cells.
Which does what exactly?
It actually allows the spleen to contract and tamponade its own bleeding. Their organs have more robust collateral blood flow. Because of these anatomical advantages, the vast majority of pediatric blunt, solid organ injuries heal without a surgeon ever needing to pick up a scalpel.
But the vast majority isn't everyone. Sometimes the biology fails. The internal bleeding refuses to stop, the child's blood pressure begins to trend dangerously downward, and the non-operative management strategy fails. In those critical moments, you need an active intervention to stop the leak. And this brings us to a highly specialized procedure called angiography with embolization, or AE.
A phenomenal tool.
Let's break down exactly how this mechanical intervention works, because it really is a marvel of modern medicine.
It is an incredibly elegant alternative to an open laparotomy. Imagine the procedure utilizing the Seldinger technique. An interventional radiologist punctures a major access vessel, typically the femoral artery in the groin. They insert a wire, and over that wire, they thread a tiny, flexible microcatheter.
All the way up from the leg.
Yes. Using real-time fluoroscopy continuous X-ray guidance, they navigate that catheter up through the aorta and directly into the specific, tortuous arterial branches feeding the spleen or the liver.
I always think of it like trying to navigate a massive city's traffic grid. The angiography part is like putting a GPS tracker on the cars. They inject a radiopaque contrast dye through the catheter, which lights up the arterial tree on the X-ray screen. They watch the flow of the dye to spot exactly where it is leaking out of the vessel.
A blush of active hemorrhage.
Exactly. They find the exact street where the flood is happening. Once they identify the precise site of arterial extravasation, they move to the embolization phase. Through that exact same microcatheter, they deploy mechanical occlusive devices, often tiny platinum coils, gelatin sponge slurries, or special liquid embolic glues.
They build a hyperspecific roadblock deep inside the organ's vasculature. They plug the hole from the inside out, stopping the hemorrhage while preserving the blood flow to the rest of the healthy tissue.
It's an incredibly targeted intervention that avoids the massive physiological insult of cutting a child's abdomen open. But here is the massive paradox that the Nadich study addresses. In the adult trauma population, if you present with a high-grade liver or spleen laceration and evidence of active arterial bleeding, angioembolization is standard operating procedure. It is utilized aggressively.
But in the pediatric blunt trauma population, the literature shows it is used in a meager 3 to 4% of patients.
And that massive discrepancy in utilization is the crux of the debate. Why is there such hesitation among pediatric trauma surgeons?
Is it a technical fear that children's smaller, more reactive arteries are too prone to vasospasm during catheterization? Is it a pediatric apprehension regarding the prolonged radiation exposure required by continuous fluoroscopy?
Or is it simply an entrenched cultural dogma within pediatric surgery that dictates kids heal, just wait longer, don't intervene?
Exactly. The Nadich study was designed to penetrate that exact dogma. This was a planned secondary analysis of a massive, prospectively collected data set. They aggregated data from 10 Level 1 pediatric trauma centers across the United States, collected between April 2013 and January 2016.
And we should clarify the caliber of the institutions involved. A level 1 pediatric trauma center represents the absolute pinnacle of trauma readiness. These are massive tertiary care academic hospitals with every pediatric surgical subspecialist and interventional radiologist available 24/7.
Right. So across these 10 elite centers, over nearly a 3-year period, they identified 1,004 pediatric patients under the age of 18 who had a documented blunt spleen or liver injury confirmed on a CT scan, a massive cohort of over 1,000 injured kids.
And remember, we said 8E was rare at 3 to 4%. The actual data breakdown they found was even more astonishing. Out of 1,004 patients, only 30 underwent diagnostic angiography. That is just 3.1%.
And of those 30 who actually had the catheter threaded up to take a look, only 17 underwent embolization. Only 17 children out of 1,000 had a coil or a plug deployed to mechanically stop the bleeding. That is a utilization rate of 1.7%.
When I first parsed that data, I had to stop and verify the numbers. 17 patients across 10 elite hospitals over 3 years. That is a microscopic sample size.
Very small. But the acuity of those 17 injuries is what makes the analysis critical. They weren't just embolizing minor capsular tears. The injuries targeted were roughly split. 36.7% were spleen injuries, 33.3% were liver injuries, and 30% were a combination of both.
And the vast majority of these were classified as severe grade V or grade 6 injuries on the AST organ injury scale.
To contextualize that severity, a grade V splenic injury means the spleen is completely shattered, or it has a massive vascular injury that devascularizes more than half of the organ's tissue. A grade 6 liver injury is a complete avulsion, where the liver parenchyma is essentially torn away from its primary blood supply.
These are catastrophic, imminently life-threatening anatomical failures.
Yes.
So they take these 17 kids with fundamentally destroyed organs into the interventional radiology suite, and they deploy the coils. And the physiological response in the spleen, well, the data is almost unbelievable. For patients with embolized splenic injuries, the splenic salvage rate was 100%.
It is an absolute triumph of targeted intervention.
100%. Every single child who had their bleeding spleen coiled avoided a surgical splenectomy. And we need to emphasize why salvaging the spleen is so vital in a pediatric patient. It's not just a blood filter, right?
No, it is a critical organ for their immune system, specifically for fighting off encapsulated bacteria. If you remove a child's spleen, you expose them to a lifetime risk of OPSI.
Overwhelming post-splenectomy infection.
Exactly, which carries a shockingly high mortality rate. By using the coils, they save the organ and preserve the immune system.
And the power of that intervention becomes even clearer when you look at the control group. In the angiography-only group, the kids who had the catheter inserted, but where the radiologist opted not to deploy coils, 2 patients eventually continued to bleed, failed their non-operative management, and had to be rushed to the OR for complete surgical splenectomies.
So when you look at the overall failure of non-operative management, meaning the watch and wait strategy failed and necessitated surgical intervention, 33.3% failed in the angiography-only group, whereas only 23.5% failed in the angioembolization group. The coils definitively altered the clinical trajectory.
For the spleen, absolutely. But trauma physiology is rarely uniform, and we have to contrast that miraculous splenic success with the reality of the liver data.
The liver data tells a significantly more complicated story.
It does, and it forces us to discuss the fundamental anatomical differences between the 2 organs. Hepatic, or liver angioembolization, was significantly less effective in avoiding subsequent operations. Fully 50% of the liver AE patients required an operative intervention after their embolization.
Now, keeping the tiny sample size in mind, this was 4 out of 9 patients, it still represents a massive divergence from the splenic success rate. 2 of those patients required an open operation for continued bleeding control, and 2 required an operation to place surgical drains because of biomas or fluid collections.
Why the stark contrast? If the physics of plugging an artery works perfectly 100% of the time in the spleen, why does it fail half the time in the liver?
It comes down to the liver's incredibly complex dual blood supply. The spleen is essentially a giant single-source vascular sponge fed exclusively by the splenic artery. If you plug that artery, the inflow stops. The liver, however, receives oxygenated arterial blood from the hepatic artery, but it also receives massive, high-volume venous blood from the portal vein,
Which drains the entire intestinal tract.
Exactly. So an interventional radiologist can perfectly navigate a microcatheter into the hepatic artery and coil a bleeding branch. But if the severe blunt force also tore a major branch of the portal vein, the liver will continue to hemorrhage massively into the abdomen. And portal venous bleeding is exceedingly difficult to access and control via standard arterial catheterization.
And it's not just blood they're leaking, right? It's bile.
Yes, bile. The liver parenchyma is laced with an intricate network of biliary ducts. When a grade V laceration crushes the liver, it tears those ducts. Bile is highly caustic. If it leaks into the peritoneal cavity, it causes severe chemical peritonitis and intense inflammation.
Coiling the artery does absolutely nothing to stop a bile leak.
Right. The child will eventually become toxic, requiring a surgeon to open the abdomen or use large percutaneous catheters to wash out the bile and place surgical drains.
That dual anatomy perfectly explains the 50% failure rate. But even within that failure, the authors note a crucial silver lining. Even though half of those liver patients needed an open operation, only one single patient required a hepatography, which is surgically suturing the liver tissue back together, and absolutely zero patients required a formal hepatectomy.
Where a surgeon has to resect a massive chunk of the liver, yeah.
Right. None required that.
That is a brilliant clinical nuance to extract. While the angioembolization didn't perfectly prevent an operation, the data strongly suggests it downgraded the severity of the operation required. By shutting down the high-pressure arterial bleeding with coils, the radiologist likely turned a catastrophic, uncontrollable hemorrhage into a manageable, slower venous ooze.
It bought the surgical team time and visibility.
Exactly, to clean up the abdomen and manage the bile without having to amputate half the organ.
But there is a ticking clock underlying all of these physiological victories. And the timing data extracted from this study is where the real controversy ignites.
In trauma surgery, the most precious commodity is time. Time is tissue perfusion. Time is coagulation. Time is life.
So clinical logic dictates that if a child presents with a shattered spleen, a falling blood pressure, and active extravasation on their CT scan, you mobilize the interventional radiology team immediately. You rush them to the suite to deploy those coils.
You'd think so.
But the NADH study revealed a shocking delay. Very few angiography studies were obtained early in the patient's course. Only one single patient out of the entire cohort underwent angiography within 1 hour of arriving at the hospital. Only 7 underwent the procedure within 3 hours. The median time from hospital arrival to angiography was 6.43 hours.
Let the magnitude of that delay sink in for a second. Nearly 6.5 hours. 6.5 hours of a critically injured child lying in an ICU bed, actively bleeding, receiving endless transfusions.
Perhaps that meticulously balanced 40% whole blood ratio we discussed in the Feeney paper.
Right. All while the surgical team watches, waits, and observes before finally deciding the non-operative strategy has failed and moving the child to the IR suite. This raises an important question.
And here is where the authors of this study make a very bold and frankly controversial suggestion regarding national trauma standards. The American College of Surgeons, the ACS, sets rigorous operational guidelines for level 1 trauma centers. One of their strict mandates is that interventional radiology capabilities must be fully available and operational within 60 minutes of a patient arriving.
It's a foundational rule.
But the authors of this paper look at their median delay of 6.43 hours, they look at the miraculous 100% splenic salvage rate, and they suggest a correlation.
Hey.
They argue that because these pediatric patients ultimately did well despite a prolonged time to the IR suite, perhaps the ACS guidelines could be relaxed. They hypothesize that emergent IR availability within 60 minutes might not be strictly necessary for pediatric trauma centers.
And this is where we and the peer-reviewed commentary, explicitly noted alongside the source text, must forcefully challenge that conclusion. This raises an important question about how we interpret retrospective success and the profound danger of survivorship bias.
Survivorship bias is huge here.
It is a massive, logically flawed leap to state, well, the specific patients who survived to get angioembolization at 6 hours had great outcomes. Therefore, we don't need rapid angioembolization in the first hour.
Right. It completely ignores the invisible numerator.
Yeah.
What about the patients who needed IR in the first hour but didn't survive to hour 6 because the capability wasn't mobilized?
Precisely. It is easily imaginable and frankly clinically certain that emergent IR is absolutely necessary in specific cases of catastrophic high-flow arterial bleeding where the child's compensatory reserve fails rapidly. You cannot coil a patient who is already exsanguinated?
No, you can't.
Furthermore, let's look back at the patients in the angiography-only group who failed non-operative management. A full third of them failed. We have to ask, could the prolonged 6-hour delay to angiography be the exact reason why their conservative management failed in the first place.
If the trauma team had aggressively embolized the bleeding spleen at hour 2, would they have prevented the physiological exhaustion and surgical failure at hour 6?
Exactly. It's the classic correlation versus causation trap in statistical analysis. You absolutely cannot use the biological resilience of the survivors to justify lowering the systemic standard of readiness for everyone. And this intense debate forces us to circle back to the ultimate, inescapable encumbrance of this study, the sample size.
Yes. We are attempting to draw sweeping national protocol conclusions based on exactly 17 patients who received angioembolization across 10 elite hospitals over a 3-year period. Statistically, that is roughly half a patient per hospital per year.
You simply cannot rewrite American College of Surgeons trauma guidelines and relax critical resource availability requirements based on an N of 17.
Plus, we have to contextualize the era of the data. This cohort was collected between 2013 and 2016. In the timeline of medical technology, that data is essentially a decade old.
Right, the technology moves so fast.
The resolution of modern CT scanners, the maneuverability of the microcatheters used in IR, and the variety of embolic materials have all advanced significantly since 2016. So when the authors pulled back from that controversial suggestion, their final, more measured conclusion is undeniably the correct one.
Which is?
This study provides strong, compelling support that angioembolization can be an incredibly valuable organ-saving tool in pediatric patients, specifically for salvaging the spleen. But the data screams for further, prospective, multi-center research to identify exactly which physiological markers dictate who needs it and exactly when in the golden hours of trauma they should get it.
If we synthesize the physiological lessons from both the FENI fluid data and the native source control data, we are witnessing a beautiful, albeit complex, maturation in the field of pediatric trauma care. For decades, the default intellectual setting was extrapolation.
Take the adult data, adjust the dosage, use component therapy, wait out the bleeding, and cross your fingers.
Exactly. But what these researchers are proving is that saving a child's life requires interrogating and dismantling those legacy assumptions.
Exactly. The future of trauma surgery isn't about broad, scaled-down algorithms. It's about hyper-specific, biologically targeted interventions. It's about recognizing that a 10-year-old's complex physiological response to hemorrhagic shock demands a highly specific, mathematically proven ratio of whole blood, that magic 40% threshold, to stave off the lethal triad and prevent mortality.
And it's about understanding the delicate, robust architecture of a child's spleen and recognizing how a precisely placed platinum coil can result in a 100% salvage rate, saving them from the lifelong immunological compromise of a splenectomy.
It's incredible.
My core belief regarding medical research has always been that knowledge is only valuable when it is rigorously tested against reality, and that multiple analytical perspectives are what ultimately enrich our understanding of human biology. We absolutely must question the dogmas, whether it's the efficacy of component therapy or the rigidity of the 60-minute IR rule.
But we have to be careful.
Yes, we must be fiercely protective of the scientific method, critically aware of confounding variables, and deeply wary of basing national protocols on small sample sizes. We use this data to illuminate the muddy waters of pediatric trauma, but we don't pretend the water is perfectly clear just yet.
Which leads us with a provocative final thought for you to mull over as we close out today's deep dive. We opened by talking about the false comfort of the miniature adult fallacy, the desire for easy, scaled-down solutions to complex biological problems. But if a child's body is so fundamentally, profoundly different from an adult's controlled, proven by how beautifully their spleens respond to targeted embolization, and how exquisitely sensitive their very survival is to the exact ratio of whole blood in those first 4 chaotic hours, what other standard emergency medical protocols are we currently using on children every single day in hospitals across the world that are actually just adult protocols in disguise?
It's a sobering question.
It really is. If we're getting fluid resuscitation and splenic source control wrong by treating them like adults, what else desperately needs its own dedicated, biologically rigorous pediatric deep dive? Thank you for joining us as we explored the cutting edge of trauma science today. Keep questioning the standard, keep looking for the biological nuance, and we will catch you on the next deep dive.